Hello and welcome back to the show. I am excited today to introduce you to our special guest, Dr. Kassia Beetham. She is an accredited exercise physiologist and is the course coordinator for the Master of Clinical Exercise Physiology at ACU's Brisbane campus. Kassia has a background in research and in particular the physiology of exercise in pregnancy and postpartum. Kassia's program of research focuses on the cardiovascular changes in both the mum, fetus and placenta in response to exercise from conception all the way through to birth and into the first year postpartum. I'm super excited to share this conversation with you. I learnt so many things or even had a little bit of a shift of perspective on many things during pregnancy and the post-birth period that I'm sure you are going to gain valuable insights into as well as you listen to the conversation. Just a quick reminder for our disclaimer that all information and content that is shared within these episodes are intended for entertainment and general information only, and that should not be substituted for medical advice, diagnosis, or direct treatments. So let's jump into the conversation with Kassia. Hello, Kassia. How are you today?
Great, thank you. How are you?
Good, good. I want to say thanks so much for coming on the show before we even get started. I'm really excited for this discussion around pregnancy and exercise and the research. So thank you so much already. I'm excited.
You're
Um,
welcome. Me too.
can we just have a little bit of a chat about your background and your career journey and where you are now and how you got there?
Yeah, definitely. So I've covered off a few fields in the last however many years, over a decade. I graduated as an accredited exercise physiologist, and I went straight into my PhD looking at the effects of an individualized exercise intervention in patients with kidney disease. So that had a whole heap of comorbidities and just trying to get them as healthy as possible. Finished my PhD, then went and did my postdoctoral research, a fellowship in Sydney, looking at children with developmental disability and how they play on the playground. So a bit of a pivot there,
Yeah,
and
that's cool.
moved back to Brisbane to take a teaching and research academic position. And in sort of that period, I had become pregnant with my first child, and realized that the evidence on exercise in pregnancy was not there. Like, I was an exercise physiologist and a researcher. I thought I should be able to figure this out, and I just couldn't. I found it quite difficult. And at the same time, just fascinated by all the physiological changes that occur during pregnancy. And I found myself just reading about pregnancy physiology in all my spare time. So when I moved into the lecturing position, did another pivot into focusing my research program on physiological changes in pregnancy and postpartum, and how we can influence those changes and optimize them with exercise. So here we are now.
That's really cool. I find that the physiological changes and things that happened during pregnancy, I don't remember really learning a lot in my degree about that at all. Like, do you teach that in degrees now?
I do. I don't know.
It's like forcing it on everyone.
Yeah, I crowbar it in there. But still not a huge amount, because there's not a lot of space in the degrees
Mm,
to cover it. But definitely well, pregnancy is relevant in the musculoskeletal units, in
yep.
the complex conditions units. It is there in some way across the degree. And I'm just like a massive fangirl of pregnancy physiology, and I just add it in wherever I can, like in the cardiac.
Yep.
Do you know the pregnant heart increases by, over 25% during pregnancy? Then
Just
that's more than
dropping
an
it in every
athlete.
every subject.
I'm like, the students are like,
Like Thorium cardiac. Yeah.
yeah.
Yeah. I'm pretty sure we did like I think it was like life and development or something, our subject. And it was basically like the stages of like growth. And I think that's where we covered, like it was fetal development in pregnancy that we actually covered,
Yeah.
not anything to do with the actual mother.
Yeah.
I don't remember learning anything other than like postural changes. That was like back
Yeah.
pain.
Yeah,
But
yeah,
nothing else.
yeah,
And then I'm pretty sure it was like exercise during pregnancy for fetal growth and development and risks.
yeah,
And then it was like, okay, now we're into like birth and how we like developmental stuff.
yeah.
So it was like hardly anything. We didn't
Mm,
learn. That was it. I'm pretty sure that was it, the whole
yeah.
thing.
I
Maybe
love
on.
babies. Babies are amazing. So cute. But the mum has been just woefully neglected in this whole process. And what happens to the mum is just mind-boggling.
Mm.
And I think it's only now that we've got more female scientists. Um, this is completely maybe talking outside my scope, but I think now we've got more female scientists and practitioners who are going through this, and
Mm.
yeah, we're like, but this needs to change. We need to know more about this. Like, we're important too.
Yeah. And I mean, it's so interconnected with the baby anyway, like what the
Mm,
mother does. So I'm sure we're going to touch on all of this anyway, which is
yeah.
exciting. But did you actually, I mean, I'm going off a bit of a limb here, but did you actually have like pregnancy-based complications that made you want to research this more? Like, was there something specific or were you just generally interested?
I was just generally interested. I was running, just a
Mm.
bit of a weekend warrior, runner, 3 times a week, 10 kilometers or so before pregnancy, um, and doing higher intensity resistance circuit based training. I wanted to continue that during pregnancy. But the advice I was receiving from different practitioners was really different. And I knew the basic guidelines, which are very basic.
Mm.
And I didn't know how to fit my experience in with the guidelines, and then what practitioners were telling me. There was things about not going above certain heart rates and only
Oh, the
lifting a
heart
certain
rate. Yeah.
amount. And it was very confusing and very stressful. It's already such a stressful time, and you want to do the best thing for everyone involved, yourself, your
Mm.
baby, don't want to cause any harm. And I continued my exercise going, okay, I think I'm pretty sure this is fine. But pretty sure is a very stressful, like it's
Yeah.
not 100% sure. So even with no complications, I was a bit nervous about what I was doing, and how this could be. Is this good for my baby? Is this bad for my baby? Does it have no effect?
Mm.
Yeah, I wasn't 100% confident, which is not a nice feeling when there's already so many other stresses going on.
Yeah, and I can imagine there's a lot of opinions thrown at you too, right? Like you shouldn't be
Yeah,
doing that or you should be doing this or and there's so
yeah.
much caution, I think, with also practitioner advice. Like
Mm,
they're too scared to say, yeah, you can do high intensity or
yes,
running,
yeah,
out of like, oh, I don't want to say the wrong thing, just in case.
yeah. And complications and adverse events do happen. And having been there myself, you look for things that you've done differently, or what things you have done which could have caused that. I think that's just human nature. And
Mm.
I think no practitioner wants to put their name associated with advice. So anything you've been doing that's slightly out of the normal, you go, that's it. That's the reason that this terrible thing happened to me, which in most cases it's probably nothing to do with it. But I think that that's part of the
Yeah.
hesitancy, and um, people like practitioners wanting to support and agree to things that are slightly outside what the standard person does.
Yeah, I couldn't agree more. I feel I work with a lot of preconception health clients who are having difficulties in terms of fertility. So there's always this I guess fear around like it's always blame on the exercise every time that it's like I
Mm,
went to Pilates in the morning and then I had a miscarriage and it was like I don't think it was the Pilates that really did that. Like there's so many other things involved in like the cellular development and like continuation of pregnancy that it's like the exercise side is probably very minimal, but it's
mm,
funny that it's always exercise is always the label and I don't know whether that comes also from like the old theories that you shouldn't be exercising above 140 beats per minute in your heart rate and
mm,
all these
mm,
like fears that have been instilled around it when in reality there is like we're going to talk about the benefits of exercise versus not actually doing anything. So It's funny though. I hear it all the time and you're like, oh, I
Yeah.
guess if you don't want to do it, like it's better to just not because,
Yeah.
your headspace is important and if you
Yeah.
regret anything. So, but
Yeah. I'm not sure if this is supported in the research, but it seems, and this happened to me personally as well, just from a very early miscarriage, is that exercise could potentially bring on the bleeding, but it
mm,
doesn't mean that it's caused the miscarriage itself, which in most cases it would be
yeah.
genetic abnormalities. But if you think about if you've got a pool of blood sitting in your uterus and then you're bouncing it or shaking it around, with exercise, that movement could just trigger some of the blood to come out, which is when you become aware of the fact that you've had a miscarriage. So
Oh,
that
yeah.
could be something to, like, the associations put together, even though one's not caused the other.
Yeah. It just makes
Yes,
it visible.
visible. Yeah, that's right.
Yeah. Oh, I would love to see if there is like I can just see myself writing all these topics down for like diving into the research after we finish this call.
Yeah. So
What can
in
I
our
find on this?
research, we've been adding in, have you experienced first trimester bleeding or a miscarriage, and trying to just line that up more with what's happening when people are exercising. And like, almost certainly I would say it's a coincidence, but the exercise is not causing, like, we know they're genetic abnormalities,
Yeah.
but if we can provide some more evidence to that, I think that might give exercise a bit of a break from always being the
Yeah.
guy.
Yeah, because I wouldn't have even thought about like that, even as a
Yeah.
practitioner, thinking like it's already there, except now
Mm.
it's just because you've mushed it around, it's coming out,
Yeah,
like,
yeah, yeah,
which
that's
makes a lot of sense actually.
yeah.
Um, so that is good to know. That is good to know. When you tee that up in the research, I'll be sharing that with my clients.
Yeah, I'll let you know. I'll get onto it after this.
Um, yeah, well, I'm expecting all these papers after today. Um, but yeah, that's one thing I would really actually like to talk a little bit more about is the hormonal status with pregnancy because like we know that heaps of that. Well, that's pretty much the whole thing changes, and the effects that this might have on the body from an exercise point of view. Is it these things that we need to be concerned about? Like, I would love to touch. I've seen a couple of your posts on your Instagram, which I'm also going to share that link in this show because I feel like it's a great resource. But in regard to like genitourinary system for me is most important because I do a lot of pelvic floor health. But like I'd love to dive into the hormones if you want to like take it away with what the research says.
Yeah. Yeah, so I have I've breastfed all my babies past 12 months. And so, yeah, big advocate for breastfeeding if you can do it. But even with that personal experience, I never really put together the breastfeeding and some symptoms that might occur in the postpartum period,
Mm,
likening that lactation um, state with menopause. And
yeah.
I'd listened to a couple of podcasts, and like, obviously you have a drop in estrogen that is so significant in the postpartum period that you're in a similar state to menopause. I'm like, oh yeah, duh. Like, but
Yeah.
and then I started just like teeing up some of the symptoms, and you're like, oh, the night sweats. You
Yeah.
get vaginal dryness. You get all of these other symptoms that are typically associated with menopause, and they're exactly the same in the postpartum period, and we don't talk about it. Didn't hear about it from any practitioners, and some people may not get these symptoms, but if you do get them and they are affecting your quality of life, then there's treatments available similar to that of menopause, like some estrogen creams, which are local, so they won't affect your breastfeeding supply or your lactation. But yeah, there's definitely options that um, could help you potentially continue that breastfeeding journey if that's what you want to do, but also make your life more comfortable as
Mm.
well.
I think when I first started to realize that as well as a practitioner, a lot of I had a lot of clients that had prolapse that just couldn't, and they were breastfeeding for quite a significant time, like past the 12 months, onto the 2 year mark. And a lot of them were just so like, why is it not getting any better from
Mm,
like I've done all this work, we're doing all this strength work, and there's still these lingering symptoms of prolapse that I think I was like, this has got to be a hormonal, like this sounds like someone that I would have who is menopausal, where we're like
mm,
doing like the strength just takes so much longer to get there, and like the tissues are
yeah,
different. And I was thinking, I thought about that too. And then the other one that came up was like almost like the body fat side of it, that
mm,
metabolic sort of like tummy that wasn't like they didn't have any abdominal separation there. They like, yes, the body's changed and there's loose skin, but there was still this like same like kind of like I guess abdominal fat that they just couldn't, and they're generally super lean people. And then
mm,
as soon as they stopped breastfeeding, within like a couple of months, it was all gone. And I was just like,
yeah,
oh my gosh, this is a
yeah,
hormonal thing that I would have
yeah,
never pieced together until these
yeah,
people had mentioned that, and then seeing a
yeah,
couple of things and doing the research. So it's
yeah, that's right.
crazy.
It is crazy. And like we're biologically wired to support our infant at our own expense. I mean, that's how we keep the species going. So yeah, that's what we're meant to do is, and when you stop the breastfeeding, like you're not meant to biologically, your body's saying you're looking after an infant, you can't, we don't want you to get pregnant again. So
Mm.
we're going to drop your estrogen down to nothing. So, I mean, doesn't happen for everyone. Some people can
I was
still
going to
get
say, I've
pregnant
heard
while
other
breastfeeding.
stories.
Yeah. So this is very, very broad. Don't use this as contraceptive advice.
Yeah, that's so true.
But generally, like your estrogen is so low to, well, I mean, everything's so multifactorial. But so you can keep supporting that baby through the breastfeeding, and yeah, so your estrogen is so low that you basically have the similar symptoms to menopause, and that
Mm.
includes some things, or and also, sorry, I'm skipping around. There's so much going in my head. For those clients that you have, it's probably helpful to know that if they do want to continue breastfeeding, that it will come to an end, because that must be
Mm.
psychologically really hard to just be putting in all this work, and if it's weight loss or strength or whatever they're working towards, and not knowing, like not seeing the results, knowing that they're going to see a significant improvement and this hard work isn't for nothing, would, I think, be pretty motivating, and yeah, something that would be really important to talk through with the clients that you're seeing who are breastfeeding, that these changes may happen a bit slower.
Yeah, I think
Then,
being able to explain that, but like before, I didn't really know.
mm,
Like I
mm,
was a bit, when you're early in your career and you sort of like
yeah,
didn't know that, it's harder to explain that why. Whereas now
yeah,
you can say you're actually pretty much menopausal right now.
yeah, yeah,
And once you stop, and that gives them the confidence to go, oh, it is actually a hormonal thing, not just
yeah.
like it could be this, it could be that, and like hopefully it changes and it's not just like up in the air.
Yeah, yeah, it's nice to put it down to something else. And again, it's human nature, I think, to blame yourself. And it's like, oh, maybe it's those midnight biscuits that I eat when I have to get up to
Yeah,
feed the
the
baby and I'm
same.
starving.
Yeah. Like so from like I'm thinking about the risks involved with low estrogen when we're going through menopause, and like the bone health side of things, even like tissue weakness, muscle atrophy, things like that.
Mm.
Is that something that we still need to be concerned about during that breastfeeding stage? Like should we be doing bone health exercises and things like that, or
I think so, but it's not covered. It's such a new topic. We're
yeah.
starting to see more light that there's not the evidence to suggest that we should be treating it like that, but physiologically, I think it, yeah, is something that should be, we should keep it at the front of our minds. I mean, it seems reasonable to me to think that there's actually quite a lot of stress fractures in postpartum women, and I
Mm.
don't have any research to back that up. But with that, really, you got the calcium leaking to help support from the bones to help support the baby, and the estrogen, low estrogen affecting bone cell turnover, you're at an increased risk for things like stress fractures,
Mm.
and particularly in the sacrum and the lower back, when we have back pain, pelvic girdle pain for a number of reasons in the pregnancy and postpartum. So there's not many of us going out and getting, scans to see if we've got stress fractures.
Yeah, no.
But I would be so interested to do a study, just get every
Yeah,
postpartum
piece that together.
woman. There are some people that are particularly susceptible, and they might get picked up in sort of the end of pregnancy in that first month postpartum, with like severe back pain type situation where they get a scan and like, oh, yeah, you've got a stress fracture. But I wonder about all the others, particularly people who do extended breastfeeding, what the state of their bone health is like, and if there are any aches and pains, which may actually be stress fractures, which might slightly change how we prescribe them exercise. So it would be helpful to know.
Yeah. I'm just thinking also like it's quite similar to like those who have like hypothalamic amenorrhea, for example, where their estrogens have dropped so low from and loss of period from maybe
Yeah.
disordered eating,
Yeah.
and their bone health is a problem. And that's something that's, there as well. And it's like that's at a pretty, like if someone is breastfeeding for 2 years, that's a
Yeah.
pretty extended time of like
Yeah.
no low estrogen,
Yeah.
maybe like not the right prescription to help foster all of those physiological changes that we could potentially be really impacting someone's bone health. That's,
Yeah.
increased, when they actually do go through menopause later.
Yeah. Yeah.
So I've never really thought about it like that from
Yeah.
like what other
Mm.
things, we're all really mostly worried about fixing musk problems. I
Mm.
am,
Yeah.
the people who I
Yeah.
work with. But we still have
Yeah.
all these other things that, and like even just cardiovascular health as well is a huge issue through menopause and, cortisol, inflammation, things like that.
Yeah. Yeah. That's
Whether
right.
that would be something also to be concerned about.
Yeah. It would just help provide more of an emphasis on so you're doing your exercise prescription for the conditions and whatever else is going on, but also considering the cardiovascular health and the bone health.
Mm.
So the resistance training through postpartum is so important to help improve that bone health, and that's like something I try and remember as well, because I like running and I don't enjoy resistance training so much, but I'm like, okay, I'm still like in the final sort of petering of breastfeeding, and I'm like, I need to do my resistance training at least twice a week. I know that's the
Yeah.
guidelines. So just sort of the knowing why it's important, I think, might help with adherence as well. And the
Yeah.
other thing with bone health and stress fractures is resistance training and the things to do that are really helpful, but then also the things to avoid would be, if someone's at risk, it would be helpful to know that. So, you
Yeah.
can look at things that for mechanics, which is what we often do when we have a new baby, is we have terrible posture and tilting and lifting and twisting and pulling out of a cot, and all the things that predispose to stress fracture if you're already vulnerable. But if you know that's a risk, then you could come up with strategies with your exercise physiologist on how to optimize those movements and be a bit safer in the way you're bracing and lifting and holding for extended
Mm.
periods of time.
Yeah. Definitely. I'm just thinking about how many people that may have like osteoporosis,
Mm.
later in life that may have had poor bone mineral density or the lower end pre-pregnancy. And then, that's happened and it's
Yeah.
kind of like layered on like the
Yeah.
downward spiral of decline. I'd
Yeah.
love to know that. Like if you could just piece some research together over
Yeah.
someone's whole life,
Yeah.
like
Yeah.
what that would look like. I'm just
Yeah.
be so
Well, that's
interesting.
my list.
Yeah.
Uh,
Next research project.
it's
Um,
the same as the cardiovascular health, the hypertension, the diabetes later in life.
yeah.
I've been doing a bit of research into the hypertension in particular, and preeclampsia, and how that can have the pathologic changes in pregnancy, and how they can influence, right down to the lifespan and predispose your risk later on.
Yeah,
So I
right.
think there's probably a lot of conditions that we're experiencing later in life that could be addressed a bit earlier, and hopefully sort of reduce that risk then down the track.
Mm, yeah. With the I'm just thinking also about like the mental health side of menopause. I'm just like kind of labeling them together now.
Yeah.
Um, but like there's a lot of like depression that comes around in menopause that's quite different to clinical depression because it's hormonal based, and
Mm.
postnatal depression being something that's actually quite high risk.
Yeah.
I don't think I've ever thought about it from a hormonal perspective either.
Yeah. Yeah. I think it's got something to do with it. The fact that in day 3 postpartum, you get the baby blues and your mood just like falls through the floor.
Mm,
Um, and it is hard to, it's a hard time, like, because your day 3 is when your milk comes in, and your milk comes in because your estrogen's like dropped through the floor. So there's this massive change in hormones about day 3, and you get the baby blues. So yeah, like a depression that could, continue on.
mm.
Um, so yeah, I think sleep deprivation comes into it as well, but I definitely think there's a big hormonal element to it.
That's like, it sounds like a terrible time, doesn't it, when we talk about all these things? Like, why are we designed like this? Like,
Yeah,
just give them the
it's
post-baby
worth it, I
blues
promise.
day
But
3.
yeah, it's hard. It's hard, but totally worth it.
Yeah, I
In
can't
my
even
opinion.
like I have no children. So I'm like I feel like I learn all this stuff that I'm like kind of a bit deterred from having kids.
You're
Like
like,
I don't want to fix these problems later and I know all the bad stuff that's going to happen, so I'm just not going to do it.
yeah. If
But
you're with a
it's
group of parents and you hear what they say, and it is like, I think people without children are like, oh no, I do not want this. But then you
no
realize
one's
people are talking about their children nonstop. Like, so you can see there's a
yeah,
reason. Like,
no one's ever sold
they
it to
love
me. They're
them.
all like, if I had a choice again, I would never do it. I'm like, thanks. You're not telling me, kids. Um, yeah, well, that's just given me a lot of things to think about, like, hormonally, like what's going on for them. I'm just thinking back so many people now that I'm like, oh, that's why that wouldn't resolve. Like,
Yeah,
or
yeah,
why it happened. Like, could have been way better.
yeah,
But anyway. Um,
yeah.
the other thing I love to talk about, I'd love to discuss more with you is gestational diabetes, because I feel like that's something that we probably did learn quite a lot about, in the sense of like this is a pretty big problem in pregnancy. And I know, like, I don't treat that much because most of my work is mask related, but I have had quite a few clients who have had a lot of hard times managing their gestational diabetes. And I think we've kind of, most people kind of just go, oh, it's kind of like type 2 diabetes. Like you just kind of do the same thing. But I feel like it's a lot deeper than that. So,
Mm,
um,
it's similar. The difference is, so with your hypoglycemic spikes, if you're not pregnant and you have a high carb meal, you get this big spike up and down. But in pregnancy, you become more naturally insulin resistant, and that spike goes up and it stays for longer, like the hills longer. So that's it's similar management if you're not on insulin yet in terms of exercise. Like if you're doing some exercise about an hour after you eat, then that can help with that spike, and with that muscle glucose uptake, then you can sort of remove that spike a bit quicker. So that might help with feelings of tiredness,
mm,
and lethargy, and other things we know associated with high blood sugar. But at the same time, it is a natural state, so you can do things to try and help optimize, like definitely eating lower processed foods, and also regular exercise to help that glucose uptake into your muscles, ideally about an hour after eating. But I mean, it's going to have a smallish effect, so just exercising would be a good goal, I would think. And we know the effects of exercise on insulin sensitivity can last up to 48 hours. So that regular exercise as well during pregnancy. So yeah, very, very similar to non-pregnant states. But the other thing, which is an exciting space, is with the continuous glucose monitoring that are more available these days commercially, is that we're starting to get more of an understanding of how that glucose changes during pregnancy,
mm,
and there are different times when, you know, you can do all the right things and you're not going to be able to influence those spikes because your body is getting itself ready for the baby. So there's different periods where, you know, at the start of pregnancy, it might be helping you store more fat to help support the later stages of pregnancy where the fetus has a big spike in their growth. So that's when it needs more glucose to help facilitate that growth. So
Yeah, right.
it seems that we're going to find out more information soon with the continuous glucose monitoring and how these levels change. And I don't think it's going to be a change in insulin and glucose that looks like this. I think it's going to change in line with the fetus's growth and when it needs more,
Yeah.
demands increase. So we know like placental growth factors peak at around mid-pregnancy. So sort of we're learning about the placenta and how that growth changes. And it's not just a sort of straightforward increase that I think there will be fluctuations. So all you can do is, and people who end up with gestational diabetes have a maladaptive response to this normal physiological change in pregnancy. It's just considered maladaptive. So like more insulin resistant than normal or yeah, something along those lines. So I think it's an interesting space, but all we can do in the meantime is you know, reducing those processed foods to try and lower those spikes, but certainly not being on any sort of highly restrictive, low carb, ketogenic diet. It doesn't appear to be safe at this stage because there is a reason that your glucose goes up, and that's it needs to be transferred through the placenta and bloodstream into the baby. So, you know, just a normal, healthy, balanced diet, low processed foods, low sugar, and exercising regularly to maximize that glucose uptake into the muscles.
And is there any research that shows, like we don't know why particular, like you just kind of get it or you don't, right? Like apart from this maladaptive response, but there's nothing precursor wise that we can be concerned about for someone to show their risk aside from like general health markers. Is that right?
Yeah, general health markers. Often these things are like a perfect storm. So genetics is one.
Yeah.
Inflammation is a big one as well, which is why that healthy lifestyle is a risk factor as well. And just the perfect storm of things happening, and then that triggers that maladaptive response.
Yeah, okay.
There seems to be a bit of research. So this is getting a bit beyond my knowledge, but at the cellular level around endothelial dysfunction and nitric oxide and issues there. So they definitely it's not, you're not getting gestational diabetes because you've had too many biscuits. Like it's genetically, there might be something slightly different with at the cellular level. So that's where the genetics comes into it. And if potentially combined with other factors, including high inflammation and other things, and that can trigger that response to be slightly different to what it's meant to be.
Yeah, right. I can just, there's a couple of people I'm thinking of who they've been super healthy, active people their whole life and have ended up with gestational diabetes, and you would have never thought it. Like you just think like, you know, obviously this is just, I've just been like, oh, that's luck of the draw.
Yeah.
But I know their mum, I think their mother had gestational diabetes, so maybe there was that genetic component for them particularly. But then there's other clients I've had that I've never prioritized exercise, been quite overweight, inflammation levels probably quite high. They've just not really been in the health space, shall we say, and have been completely fine. And you would expect that would have been, you know, the perfect ingredients for someone to end up with gestational diabetes in pregnancy. So it is, I find it such an interesting because like it is just like you don't know if you're going to end up with it or not, and you can do so much to prevent it, but probably can't at the same time.
No, I think there's quite a few ingredients that go into it.
Yeah.
And some people, some are, weighted more than others. So yeah, bit of luck of the draw. And I mean, we're seeing now that type 2 diabetes is even more genetic than type 1 diabetes, when previously we thought type 2 diabetes was, almost purely lifestyle related.
Mm.
But again, it's that perfect storm of genetics and something happening at that cellular level, not being able to adapt to an environment that's suboptimal, with cortisol and inflammation, and then triggering that cascade of that pathway.
Yeah, I'd love to read more about the endothelial
Mm,
function and all of that. Would
yeah.
sounds really interesting from
Yeah, I've been looking at
um
that from the perspective of preeclampsia.
okay.
So that's even preeclampsia is even less likely to be lifestyle related. It's hard to predict, but it's like in that perfect ingredient, there seems to be problems with placentation, so the implantation of the placenta, how that implants,
Oh, wow.
combined with some endothelial dysfunction and a few other things mixed together, and you end up with resistance of the vessels at the placenta, which increases the blood pressure, and then that just has downstream effects over time. Um,
Mm. I
but
know
yeah,
I've had a couple of clients with that have had a history of endometriosis and lots of scarring through the
yes,
endometrial
yes,
lining. So
mm,
that makes like to me that's like, oh, that makes sense, like how that fits in. But
yeah,
yeah, placenta previa is an interesting one. I did want to talk a little bit about all of that because I did talk like reach out on Instagram about this with safe exercise because there's not
mm,
much research on it, unfortunately, with
yeah,
whether or not like I get a lot of them get told to just don't do anything.
yeah,
I guess so.
yeah.
Do
That's
you do we want to talk about that or?
yeah. It's there's not much to add, because as you said, there's not much research out there. But um, if I can help explain to anyone listening what's actually happening, that might
Yeah, I think
help
that'd be good.
um, the judgment. So what we call in exercise physiology, the relative contraindication to exercise, which from a recent paper by Leah Meir and Margie Davenport on sort of changing those contraindications to exercise. So
Mm.
what, and they suggested that placenta previa be added to a relative contraindication to exercise, because it's based, the idea about not having bed rest and no intercourse, is in placenta previa, you got the placenta sitting over the cervix, and towards the latter part of pregnancy, the bottom of your uterus starts to thin, and that's to prepare for labor. So if that bottom of the uterus is thinning, that's that could be potentially tearing the placenta, which is sitting right on top. And obviously you don't want to tear the placenta. There's lots of blood vessels in there.
Mm.
So that tearing of some of the vessels causes that bleeding, that vaginal bleeding. So one of the things to look out for is vaginal bleeding. And the reason, like, the blood is coming from the placenta. So if you're getting any sort of bleeding during pregnancy, then that's a reason to stop and rest and limit your activity to try and limit that movement of the placenta, which could cause more bleeding. And the bleeding itself, or something in that process, triggers contractions of the uterus and ultimately preterm birth, which we know if it's too
Oh,
early,
yeah.
it's got negative outcomes. Um, so for a lot of women, the placenta does sit very low at the start of pregnancy. So I believe it's not an issue in that sort of first half of
Mm.
pregnancy in regards to exercise. Um, Physiologically, there doesn't seem to be a reason to limit exercise if the placenta is low lying in the start of pregnancy. It's only when it gets to the later parts of pregnancy, when the uterus actually starts to thin in preparation for the baby coming, that there's that risk of the placenta getting little tears.
When is that? When does it really start thinning?
I don't know the exact time, but the guideline is 28 weeks. So
Okay.
third trimester. I don't know if that's just
Yeah.
convenient because it sits in nicely into those tertiles, but yeah, so from 28 weeks, if you have placenta previa, they suggest no moderate to vigorous exercise. And it's a fairly low incidence of people having that very low lying placenta because most of the time the uterus shifts and the placenta moves
Moves.
out of the way. But for some people, it doesn't move. So if you do have a very clear case of placenta previa, it is wise to avoid moderate to vigorous exercise in the third trimester. As that uterus thins, you don't want to be, and I believe sexual intercourse and anything else, nothing entering the vagina, you don't want to disturb that at all because if there
Mm.
is bleeding, you're at risk of going into preterm labor. So
Yeah,
I
okay.
think if you start bleeding after 36 weeks, they'll do a cesarean and take the baby out. But
Yeah.
before that, try and keep baby in there as long as possible. So so in that review, they recommend up to that 28 weeks. If you still have placenta previa, then trying to just monitor your symptoms, and it's a relative contraindication, and potentially still continuing that moderate to vigorous exercise, the lifting, the aerobic, as long as there's no symptoms and no bleeding,
Mm.
then or not even any discharge, I would think. Anything coming out of the vagina, I'd be very, you'd probably want to caution around, having a good look for the patient, that is not yourself.
Yeah, don't
and,
look there.
and knowing why and what could potentially happen. I can imagine it would be very nerve-wracking anyway, but for some people exercising, and we know how good exercise is, and for some people that's, their whole identity as well, and they want to continue that higher level
Mm.
of exercise, which is completely understandable. So it is very individualized, and potentially it's okay up to the 28-week mark, and as long as there's and no sort of discharge.
Is it the pressure generated by exercise at those intensities that we're concerned about?
I think so. I'm not exactly sure. I imagine there's just a bit of movement
Yeah,
with
okay.
exercise, and that's the reason they say no sex as well. It's
Yeah.
any sort of disturbance. Like I imagine that you want to keep it pretty still,
Yeah, stable.
and high impact. Yeah, if it's already like very thin, yeah, you don't want to bump it. So maybe it's a combination of intra-abdominal pressure,
Yeah.
and high impact.
That's
That
kind of
yeah,
like the approach I've taken previously with, the clients that I've been like, I have to exercise. Otherwise, they were really worried about risk of mental health issues and general other things that they weren't taking no for an answer from a GP. So they were looking for advice around
yeah,
what type of movement would be safer
yeah,
for me. So I think, lower intensity unilateral work where you're looking at
yeah,
technique like supported seated work and breath control, things like that, are things I've
yeah,
talked through before. But I just was like twisting. I'd be like, don't twist, like anything that would be, type things. So
yeah,
it is such a hard one though. I would really love to see more research around that because I feel like safely prescribe because we know there are so many benefits, even just in exercise for placenta, the baby's growth as well, and
mm,
long-term health that you want to be able to incorporate something. What
mm,
could we advise on that safely and confidently? Because I think that's probably one area of pregnancy-related complications that we're all a bit like, oh, just do what your GP says. And
yeah,
the GPs and gynaes aren't super up on exercise anyway. So or you kind of got the half. Some of them are a bit knowledgeable, and others are just like don't do anything. Um,
yeah, yeah,
and so, yeah, I would really love to see that, but I like another thing that's you can't really run some research with that risk, I guess.
yeah. I think we'll get there eventually. It's just a slower process on these high risk conditions. Like we've got to
Yeah,
do prospective research. So we've got to see who had this condition and actually continued exercising. So we're not making them do it. They've chosen to do it.
yeah,
Look back and
yeah,
see what happened. And then we might do a retrospective analysis, which is a study we're doing at the moment with higher volumes of exercise. So women who choose to continue doing their normal exercise routines, and we monitor them and we see what the outcomes of that would be, and then we can start getting into those higher levels of RCTs. But we have to be pretty sure that physiologically and based on cohort studies that it seems to be fine. And we're getting there with preeclampsia slowly. So I feel like we will get there eventually. It will just take a while.
Yeah, okay. That makes sense though. In terms of like, I guess the phases you have to move through to make it safe for RCT. But are those so you're getting the people voluntarily in continuing with their volume or intensity with preeclampsia?
No, not with preeclampsia. Well, not me personally. It's something that we are looking at putting grants in at the moment.
Oh, right. Okay.
Yeah.
So at the moment, it'd be healthy pop type.
Yeah.
Yeah. Okay.
Yeah. So we've got one PhD student who has a cohort of very highly active women who are so keen to do research because they're the people who have been given this advice that they know is dodgy, and they're like, I'm doing it. But the fact that they've got someone watching them, they feel quite supported, even though we're not intervening at all.
Yeah, there's still some monitoring though.
Yeah, they feel quite passionate about, they're monitoring these women are, using Strava and training diaries, and they're measuring their 1RMs and all
in
to the higher
pregnancy.
level. Yeah.
Yeah, that's
and
so cool.
they're reporting back to us, and then we can see what the outcomes of that are.
That's so exciting. I remember reading, I think it was like it might have been what paper that just came out a couple of years ago with the high intensity training was now technically okay for pregnant women, like that top end capacity, because it starts with don't go over 140 beats per minute like years ago at guidelines, and now they're like, you can do a little bit higher than that, and you don't have, talk test is a thing now, and now I've got quite a lot of athletic population as well that I see that are looking for, like, is this safe for me to be doing, and like I'm like, yeah, the research is slowly saying yes, like we can actually say there's research, whereas like before it'd be like
we're getting there,
but we're at, like, it is pretty good now, like high intensity interval training and that top end of heart rate max is actually somewhat okay from what I can gather.
So we're okaying vigorous intensity, but not high intensity.
Not high.
The vigorous intensity up to 90% of heart rate max seems to be okay in most women.
For like all small snippets.
Yeah, exactly. And that's the next thing is the reason we stop at 90% is there's been a couple of studies that have showed fetal bradycardia above 90% max heart rate, but they were longer intervals. These were in highly trained women, and I can't remember the top of my head, but they were like not something that most people could usually sustain. Like there were minutes, 5 minutes.
That's
they were
huge.
a long period of time. So the next question then is, so doing vigorous intensity intervals up to 90% max heart rate seems good, but keep it short. Do like a minute intervals. We still got to find out how much we can do at that higher intensity, because you do have blood redirection when you're exercising. And so like anything, when you're exercising, your body adapts to that and it becomes healthier and stronger, and the fetus does as well. So the fetus adapts to that reduction in blood flow because it's going to the mum's muscles, and the fetus increases its heart rate to maintain the drop in blood flow to keep that same cardiac output. So that's so good for the baby. It's good for the mum to get those systems using their hemodynamic capacity. That that's not the word I'm looking for. The being able to adapt and adjust to a changing environment is a really good thing. But if we do it for too long, that could potentially compromise the baby. Like there's only so long you can adapt. It's like doing an ultra run or something.
Yeah.
Short run's great. If you run for 200 kilometers, yeah, I don't think your body can handle that.
Yeah. And I guess that's something that would change most, like, the volume that we talked about that we don't know how much we can do. I feel like that would also be very individual based on
mm,
people's general
yeah,
capacity.
yeah,
Like
exactly.
training and things.
Yeah,
So it'd be so hard to measure that and guarantee it
yeah,
across everyone.
yeah. So there has been some studies with occupational lifting that they're associated with preterm birth. So that's when you have it as your job. That's a bit different. You're doing that for a long period of time.
Mm.
And, some studies have shown that they are associated with negative outcomes. So potentially there is something there, but then we've got to find what that limit is. So we can provide women a bit of guidance who do want to do that higher volume. So yeah, it's so important for them, like physically and mentally, that yeah, I think that's a very important area of research, and we're getting there. We're working on it.
Yeah, and I feel like there's so many more like athletes advocating for this too, right? Like you're seeing
Yeah,
it, in the CrossFit scene. I think is a pretty good
yeah,
example because they're all
yeah,
like
yeah,
hardcore training the whole time.
yeah.
But I can just imagine how many health benefits there would be even for the baby, like being able to
Mm,
have those adaptations initially, like
yeah, yeah,
during that stage of growth would be,
yeah,
I could see it advantageous for health
yeah.
at some point.
It
Um,
seems they have an improved metabolic profile, and this still needs a lot more research. Um, but it does seem that with those higher volumes, the baby is slightly lighter. And
okay.
that was originally thought as a negative thing. And we're talking like 300 grams here. So not clinically significant, not small for
Yeah.
gestational age. And there's been, yeah, couple of very small studies, and we're working on it to see, that's just an improved metabolic profile in the baby, that they're slightly lighter there. Improve lean mass and less fat mass. And like, I know chubby babies are cute, but there is it's not like the chubbier the baby,
I'm in
the
life, Remy.
healthier they are. Yeah.
The rest of your life, if you're chubby, it's not cute.
No. Yeah, own it.
Yeah. I wonder how much that relates over into like baby sleep patterns and like allergies and like all this other health stuff that we haven't
Mm,
even probably like even looked at. But,
mm.
just behavioral issues later. Like I wonder, like I'd love to know. It'd be so cool. Like I can see why your research would just be like so much stuff you could look at.
Yeah.
Because like, we can use exercise for so many other things to improve in health. Like how does that transition over into first couple of years of the baby's life?
Yeah. It's a very untapped market,
Yeah,
I
imagine if
believe.
all the mums knew that they could do high intensity interval training and it was like improved a baby's sleep or something. They'd be like
Yeah.
pregnancy like
Yeah. You'd get 100% adherence
it's so
for
good.
sure.
Like your baby will sleep
And
later in life if you do this now.
yeah. And you don't have to spend $2,000 on that self-rocking bassinet. That's
Or like
financial
a
benefit
sleep
too.
school.
Yeah. Yeah,
That would be
100%.
pretty crazy. But actually, speaking of like adaptations and things, one thing I read on your Instagram was the sweat mechanism that changes during
Mhm.
pregnancy.
Mm.
And that's like a body temperature regulation. Is that correct?
Yeah, that's I've got this really great flow chart that I'll send to you that my PhD students put together. That's why I'm just looking off to the side. So she's tracked how that physiological change occurs. I can't find it, so I don't think it's on this chart. I'll send it to you anyway.
Yeah, that'd be
Um,
helpful.
but
That'd be good.
yeah, there's a reason that you're a hot sweaty mess when you're pregnant, and because your thermoregulation does change, because we know that if you get too hot during pregnancy, that
Mm.
can have a teratogenic effect and be very detrimental to the baby. So your body is pretty good at trying to keep that down and monitor that. And one way we know we can cool ourselves down is by sweating. So
Mm. That's so
if you're
cool.
getting slightly hot, your body starts sweating to try and maintain that level
Like, I
that's
mean,
appropriate.
I knew that was a thing for general sweating and cooling, but I didn't realize it was like even better for pregnancy.
Yeah,
Like that's one question I always get asked is like, I shouldn't get hot while I'm exercising. And sometimes it's
yeah,
hard to explain to people that like you can get you can exercise and feel like
Yeah. Yeah.
warm, but you
Yeah.
don't want to be overheating and
Yeah.
are doing yoga or like those types of things.
Yeah. Yeah,
Um,
exactly.
but it is also good to know to tell people that, like, I think they get nervous when they're extra
Mm,
sweaty, that they are getting
mm,
too hot. It's a sign as well, but it's also a
yeah.
good thing to now say, like, your body does that to help keep you cooler so
Yeah.
that you're not tapping into that. So,
Yeah,
is there
that's right.
like like apart from telling someone that not to be overheated, is there something that
Mhm.
we can actually communicate the temperature thing with in its sense of the wrist?
Mm. Um, yes, so I just bear with me. I've got some so systematic review looked at the effects of exercise on core temperature
Mm.
and that level. So it's actually they found that it's actually very hard to increase your core temperature during exercise.
Yeah, right.
So that
That's
increased
good.
heat you feel, that's on your skin. Like that's on the outer, that's not your core temperature. So above 39 degrees seems to be, you start to see some negative effects. And it's
That's
very
high.
hard to, yeah, it's
That's
high.
like viral infection high.
That's viral. That's if you have a fever, which could very well happen during your pregnancy, that is so much worse than,
Yeah.
your regular exercise where you may be increasing um, a couple of decimals in your core temperature. You hardly increase your core temperature at all.
Yeah. And you
So
can
if
cool
you
down
have a
pretty quick.
fever, yeah, if you have a fever, um, yeah, that's far worse. And still, most of the time, that is okay. Like it's only in those rare cases that it can harm the fetus. Like if you get a fever, there's a very small percentage that could lead to
Yeah.
something else. So you take the Panadol and you get it down as quickly as you can. It's still probably okay. But yeah, exercise can't increase your core temperature that much unless you're doing like really extreme things. Getting heat stroke, maybe hot saunas, hot yoga,
Yeah.
exercising out in the desert. Probably don't do that. You're
Yeah.
going to increase your core temperature more. But just normal sort of getting hot and sweaty, it's not going to do it.
Yeah. That's I also think about how many people live in continents where it's like
Mm.
extremely hot.
Yeah,
And
that's
we're
right.
like, just like keep a bit cool. And they're like, you're probably
Yeah,
yeah.
yeah, yeah.
Yeah.
And you will sweat more. So if you don't want to get really sweaty, just wear like comfortable clothing. So, but yeah, let your body do its thing.
Yeah. I actually
If you're
didn't know
not
that.
sweating, that's more of a problem.
Yeah,
Um,
yeah, I'd be concerned then. Like
yeah,
something's
yeah,
wrong with your sweat mechanism. Yeah.
yeah,
Yeah. Well, that's really good to know actually, because that's one thing that I feel like I get asked all the time. I didn't realize your system changed with or was better at the sweat mechanism for that reason.
yeah,
I do know now though that everyone always reports feeling more sweaty and more hot, like
yeah,
or that's something that they picked up on when they didn't know they were pregnant yet. They're like, I was exercising, I
yeah,
was just getting so sweaty, and I was thinking,
yeah,
oh, I didn't realize that's actually like a thing. So
yeah, yeah,
that's also really interesting. But good to
yeah,
explain to people that, you need, it has to be pretty high. So,
yeah,
because I think that also then falls into the intensity side. Like people don't want to get
yeah,
too hardcore in their intensity because they're
yeah,
worried about their temperature, but they're also
yeah,
healthy and fine
yeah,
and just
yeah,
wanting to exercise. So, uh,
yeah,
finding the balance
yeah,
can be quite hard for them. But
yeah, exactly. I did look down that route for some research and put it in the too hard basket for now because the surface skin temperatures don't change very much, but you can get like a temperature gauge that you swallow to get a good
oh,
and that was just too hard in pregnancy.
yeah.
Um,
Is it like attached to something?
no, so you pull it out.
You poop it
It's
out. Nice.
I don't know. I didn't look too far into it because I put it in the too hard basket, but some sort of Bluetooth thing measures your
Oh,
good mature core temperature over a longer period of time. So that would be cool. Maybe a job for
maybe
someone
later.
else.
You're just like fishing. You have to like bring your poop in the bag so they can get the temperature.
Yeah, yeah, yeah. I don't know the logistics, but
That sounds terrible.
yeah, I'll stick to some other things. But yeah, nearly every system changes, even like the increase in shortness of breath.
Mm.
That it, because obviously your baby's pushing up on your diaphragm and your lungs, but also physiologically, your body needs to get rid of more carbon dioxide. because your baby's producing carbon dioxide. So that's increasing your breathing drive. So even early on in pregnancy, you can start like feeling short of breath and you're like, what's happening?
I'm so unfit.
But yeah, but that's the acidity of your blood is changing to be able to get rid of that excess carbon dioxide. And then, the change in hormones makes you need to pee earlier in pregnancy. Even though you're like, the baby's tiny, it's not pushing in my bladder yet. Why do I need to pee every hour?
Yeah. I talk about that a lot because that's something I deal with a lot is like
Yeah,
urgency, frequency.
yeah. It's quite incredible all the different changes your body goes through. And I think just knowing that and being able to articulate that to your clients I assume would help make them feel better and more normal and that things should resolve once, pregnancy's finished or in the postpartum period. Yeah.
Yeah, it is such a crazy time though. And because so many different body systems are affected, I think it presents differently in people as well. Like so many, my clients have said, I didn't even know this was the thing. Like no one's ever said that like this
Yeah.
would be a problem at all, or I would feel like this
Yeah.
until now. And if you haven't heard another client say it, you wouldn't really know either. Like
Yeah.
I've
Yeah.
only experienced it from other people's stories, not my own.
Yeah.
And even then
Yeah.
it probably would be different. So it's almost the same as like we talked about with menopause earlier. Like everyone experiences that so differently that some random symptoms you're like, is this related or is it not? Is something wrong?
Yeah.
And you
Yeah.
kind of have to listen, but you don't really know what you're listening for. Like,
Yeah.
do I
That's
have to
right.
be aware of these changes? Like, I don't really know what I'm listening out for for these
Yeah.
symptoms.
It can
So
help psychologically, but also that there could be treatments available. And I think a lot
yeah,
of the time in the past, it's been, are you pregnant? Yeah, of course you're tired. Whereas it could be, I mean, your heart's increasing by 25%. Anytime you've got changing cells, which is happening in every part of the body, things can go wrong. So, there could be some sort of cardiomyopathy, which is very rare. But just as an example, I think a lot of things are put down to pregnancy. Yeah, you're tired. It's hard. We get it.
yeah, keep
There
going.
are things we can do. It's in some cases.
Yeah,
So I
because you
think that just,
layer some of that all together and it's a tough time.
yeah, yeah,
I can
it's
imagine.
hard.
I'm
Yeah.
just imagining. I'm not actually serious. But well, there you go. I'm sure there are so many other things we could touch on in this topic. I feel like we've just touched the surface of so much of your knowledge. But it is like such a cool part of female life cycle, I think. Like the
Yeah,
changes that naturally occur that I still feel like we don't know a lot about,
we
really.
don't. No. It's a good
Um,
space to be in.
yeah, so I look forward to you sharing all more research with me.
Yeah, yeah, we'll do.
And in a couple more years' time, I'll get you back on and we can update it.
Yeah, yeah, sounds good.
But I do appreciate, like, is there anything else that you think you'd like to chuck in there or?
Not that I can think of. No, I think we've covered a lot of broad things.
Yeah, I think so.
Yeah, I hope
Um,
that they've provided some food for thought for people listening and sort of delve a bit deeper if they like.
yeah, if there's any questions that people have that pop up, like also feel free to shoot them over, and that way,
Yeah.
we can talk more about things that people are more interested in. But I'll link all of your Instagram profile to
Mhm.
in below. Is there any other place that you share content through? Just
No,
mostly through Instagram when
just sporadically on the pregnancy
randomly,
meme.
like everyone else, everyone listening to this is exactly the same, Dory. But it
It's
is
it's
good.
low on my priority list, but it's high on my interest. But yeah,
Takes a lot of work to
maybe on
put
the
a
school
post
holidays.
together. No, I will share that because I think it's got some really good stuff, and if you share where the research comes from too, which is nice for people to go read if they're interested in that too. So I
Yeah,
will share
yeah,
that down. But otherwise, thanks for sharing all of your information today. Really
that's
appreciate it. I
okay.
look forward to maybe another conversation a bit further into more details. Would be awesome. But
Yeah, thanks so much for having me on.
you're welcome.